So let's talk about our graft options for ACL reconstruction surgery. And what we're talking about when we're talking about a graft is the fact that for most ACL tears, the ligament itself is not repairable, or we can't stitch it back together, and it doesn't usually heal in very well on its own. So what we have to go do is take out the old ligament and then make a new one out of something. And we really have kind of four main options for what we can use to make that new ligament. There are two categories. One is using your own tissue, and the other one is using cadaver tissue, or what's called an allograft. And that's a great option for certain individuals. Most of the studies have shown that young people, we should not really use an allograft in, except for in very rare circumstances. It's something that we will talk about over the age of about 35 to 40, where over that age, the difference in re-rupture rates gets very small between the two. But allograft is an option. But when we start talking about using your own tissue, we have three options. And the main workhorse graft that we use is the patellar tendon graft. And so, the kneecap sits here, the quadriceps tendon comes down and inserts on the top part of the kneecap, and then the patellar tendon is from the kneecap down to the shin bone. And so what we do for the patellar tendon graft, as you can see, here's the bone underneath, is we basically take the middle strip of this tendon with a little bone block on each end, and we take that out, and then we prepare that, and that's what becomes the new graft. And it's nice because it has bone blocks on each side. We can control the size of it because we can always get that middle 10 millimeter strip if we want to. And it's a very strong graft, and it's definitely my preferred graft in my athletes under the age of 20. It's had the best track record in terms of re-rupture rates and an ability to get back to sport. Now, some of the risks associated with that are we do have to make a slightly bigger incision to harvest that graft, and it can be a little bit numb on the side of that incision. That goes away over time, or it becomes less noticeable. There is a risk of patella fracture. We're taking a piece of bone out of the patella, or the kneecap, and there is a small risk of fracture. It's one of those risks that's very, very, very small, but it's something that we always have to think about, and we're very careful with how we harvest that graft. And then there's a little bit of an increased risk of just having a little bit of pain in the front of the knee for a period of time after we harvest that graft. And we also cannot use that graft if your growth plates are open, because there's a growth plate right there that we don't want to harvest, and we can't put those bone blocks across a growth plate that's still growing. And so other options that we have for using your own tissue are coming around here down on the inside part of the knee just below the knee joint are 3 hamstring tendons, and we can use 2 of those. We can harvest them from right there and basically double them over and then use that as a graft. It has kind of an unacceptably high failure rate in our young athletes, our adolescent athletes, but it is something that we can use. And it's a slightly smaller incision, and it's something that is a great option for some of our athletes aged 20 to 40 that we use very frequently. The downsides of it are that we cannot control the size of it. Your hamstrings are what they are, and if they're really small, then sometimes we have to augment with using an allograft, and there are certain studies that show that when we have to augment, the failure rate goes up. And so that's not a perfect situation, but it is a really great graft option. It's something that has been used for a long time. It's a very good option. The newer option that is gaining more popularity as a primary graft option is the quadriceps tendon. And you can either take that with a piece of bone or just all soft tissue. And that's something that is becoming more and more popular recently. And it may even replace that hamstring graft as a primary graft option. Traditionally, we've used it as a revision option. So if somebody's already had some ACL reconstructions and all their other stuff has been used, it's been a great option to use when we don't have anything else to take from someone's own tissue, but we want to use someone's own tissue. And so the quadriceps tendon is actually a really great graft that's gaining a lot of popularity. The downsides of it are that it's just not everyone's comfortable with harvesting it. And then one of the things with any of these graft options, including the allograft, is the thing that we battle after ACL surgery is it just takes that quadriceps tendon a long time to come back, the quadriceps muscle, to have enough strength to go back to those cutting, pivoting, and twisting sports and not risk re-injury. And so when we're taking part of the quadriceps tendon, we worry that that might be delayed. But there are a lot of people who've been doing this and have not really had that issue long term. All right, and so those are kind of our graft options. We can either use a cadaver, or more likely we're going to use your own tissue. The patellar tendon is the one that is kind of my default graft, a workhorse graft. It's a great graft option, but we do have hamstring and quadriceps tendon available for certain circumstances. And we have a flow chart kind of down below on the website that can outline all these pros and cons, but that's just a little overview of kind of what it looks like. And it's something that I have a discussion with everybody, and we can tailor that to your own individual situation. So we look forward to helping you.